Now, the last session in a symposium is always, well, the twilight session. It's one that's not always easy to pay attention to, especially if you know what's happening afterwards, which is very, very exciting. But I'm going to leave Sylvia to explain that at the end. Now, for us, though, for the Secretariat, this is an exciting moment because well, firstly, thinking back to Boston, that this moment at the end of the symposium in Boston, where we defined together collective priorities for the next 5 years, that's what started this process going. And we've come around through a second time of doing this in Krakow. This is now our third time. And as Sylvia said at the beginning, we're looking 5 years ahead now. So we're looking at the collective priorities of the Alliance over the next 5 years. The work that had happened before this had been going on for a few months, consultations with many people in the room already, so thank you for everyone who's had input, and that helped us get to a high-level first list of priorities that form the basis for the group discussions today. And now I want to hand over one by one to the representatives of each work stream to update us on the discussions that we've had today, to help us see, are there other priorities that have come up that weren't identified before, and to start to identify some of the actions and the enablers that will be important over the next few years. And along with enablers, a very important point for us is there anyone who's not around the table that needs to be around the table? Because this alliance has grown organically. From the first meeting, that there were, I think it was almost 160 agencies signed up to the alliance informally, and then over time some have drifted off, some have come back, and I think today an important question for us is, based on the priorities of the coming years, who do we need to pull into that discussion who's not already here? So I'll leave it to the workstream representatives to decide to see exactly how they're going to share, and then maybe ask a couple of questions if I think there's anything missing. So over to you, Philippa, for the first one.
Super, thank you. So I'm going to present the great discussion that we had around service delivery. I'll just sprinkle in the actions and enablers amongst that, because we didn't really have a specific conversation on some of the last points, but I think we pulled out a few of those during the discussion. So in general, what we had proposed was three key areas of priorities. And in fact, in the end, the group really agreed with those overarching themes. So the first being the readiness for response to emergencies, so strengthening the emergency readiness and coordination for insulin access and diabetes care. The second being making sure frontline responders are ready to respond, so looking into the area of education and training of healthcare providers. And the third one also kind of looking at education and support, and that's really the importance of the community. So we continued with those three themes, and then we really expanded on some of the key actions we thought would be interesting as part of that. And then we have two kind of bonus topics, which I'll come to at the end, that actually do fit probably into three of these, but we thought they were important enough to pull them out on their own. So for the readiness to respond, there's already an ongoing work ongoing, looking at a couple of countries as examples, doing a mapping of kind of existing services and what's happened in terms of insulin supply and response to diabetes in emergencies. So that's something that everyone agreed was worthwhile to continue. But so that's kind of the last point there. And then a kind of protocol for what is IATA's role in that. But what's important in that is understanding the complementarity of IATA and of other organizations and of community organizations to WHO, and the role of WHO in emergencies as a obviously central pillar. Then we know that there are other groups that already have done some of this work about kind of defining how, there is response to needs for dialysis, for example, needs for mental health, needs for cancer support in emergencies. And so we thought it would be, really important, and I think we've talked about this before, to really properly understand how they've set up their network and how they approach, providing and engaging in that support in emergencies. So that's something that IATA can learn from to further inform how we engage. We talked about the fact that in the, again, there was a lot of discussion around coordination and the importance of coordination and the fact that there is a cluster system in emergency response, but as far as we were aware, Ukraine has been the only example where there's been a specific NCD technical working group. So this is something that we see as as important, and what can be the role, that's probably the wrong wording there that I've put there, but what is the role of kind of coordinating with that and having a technical working group on NCDs. We've had a lot of discussion over the years on, we discussed it last symposium in the breakout group of this concept of a kind of minimum initial service package, like the one that exists for reproductive health and emergencies, and there has been general consensus that it would be useful to define this package. A bit of a discussion around kind of risks of defining minimal being sometimes what ends up being, applied in protracted crises, but nevertheless this concept of having essential services with, that are important for diabetes in emergencies, and potentially some of those elements which are the key elements for the very start of emergencies. Then, I don't know if Ori is here, but we had a good reminder about how we can leverage political will and the potential capacity to utilize the recent political, or forthcoming hopefully, declaration from the high-level meeting as one way of doing that. So for the second point on equipping the front lines, we have had a discussion, idea for quite a while of seeing how we can look at having a system of online education for frontline workers in emergencies, so bringing together different agencies, and there are some agencies, including MSF, that have already started some things along these lines, but there could be, it would be nice to develop that in a more organised and inter-agency way, also considering roles of communities of practice where different frontline workers are able to support each other with their experience as well. We also had some discussion about whether there could be some core contexts where, either fragile situations or where there is more likely to be disruption to care, where actually there could be a more proactive approach of integrating into sort of, for example, university curriculums, humanitarian response to diabetes for different cadres of healthcare workers. Sorry, there's a double up there. And then just, we're doing this work at the moment, and sorry, actually, what I've typed there is not so great. We're doing a work at the moment in the service delivery working group of defining a package of adapted guidelines for diabetes, and that's something that's going to go on the website, with direct links to be able to help healthcare workers to identify the correct guidelines. So that will be an ongoing work that we'll finish in the next months, but also this value of having specific, algorithms, wall charts, a pocketbook like many of us had when we were, younger doctors, just simple tools that are easy to use in emergencies. And then the third one on power in the community. So WHO has done this work on therapeutic patient education, so there's already a number of things that we could build on, but really now it's about the practical implementation of this, involving the community and teaching the community as well as healthcare workers. And then we know that there's, different initiatives ongoing for digital education, so again, seeing where they could be harnessed and expanded or moved forward. We had a lot of discussion about this really nice idea of, diabetes camps, and whether this is something we could bring potentially to more protracted settings, and a lot of ideas around that and how we could actually, pair them with existing camps, look into different funding mechanisms for that. So I think that's something that a lot of people would be really interested to move forward and see a lot of opportunities. So that's for children and people living with diabetes. And then, we've also already engaged a bit with the Sonia Nabetta Foundation that has their warrior education courses, so training people living with diabetes to be peer leaders, to be able to support their communities. And there have been discussions with SNF about, developing a humanitarian component to that. So definitely something to look at moving forward. And then the last 2 points, which really touch a lot of these as well, were coming back to this issue of nutrition, again, seeing the real value of pulling that out as a specific topic. And this is where we come to who should we engage that's not so far engaged. So just a few ideas there. Of course, WFP, UNICEF, and the Emergency Nutrition Network. We'd like to continue the conversation from earlier today by, reactivating the nutrition subgroup, and already have some ideas about concrete actions such as an interagency protocol for research, for example, along the lines of the IRC one in Somalia. And again, the session yesterday on diabetes and pregnancy, these are the 2 topics I think we'd flagged as something we would like IATA to move forward, and so again, thinking around who we should engage.
Great. Thank you, Philippa. Just want to give a couple of minutes for any questions or comments on that presentation, including whether there's any critical gaps that anyone who wasn't in that group can see. And I just want to say also that we're aware that these can only be achieved through a number of different agencies working together, and that discussion needs to happen in a second time, exactly seeing which agencies, which organizations can see themselves in which of these activities, and how we establish that working group approach. But any questions or comments? Yes. Rachel.
Thank you, Philippa. This is service delivery? Yes. So number one, which clearly is about insulin access and diabetes care, so that's clearly within the remit of service delivery. I guess I'm wondering whether there's a bullet point needed on engaging with the private sector, or if that was explicitly decided against.
It didn't come up, actually, so we didn't really discuss that. I don't know if you have some specific thoughts around that relating to service delivery.
Well, I mean, it's access. I guess my thoughts are around access rather than specifically service
that would
delivery.
We did some discussion about it.
You did, okay.
Also, Rachel, your point makes me think as well, in the final organization of all these priorities, there could be a little bit of movement, because one of the things that was flagged earlier today is a lot of, is the nutrition work, how much of it is clinical, how much of it is policy? So it could even be that together we decide it's best housed in a different place. But all of that, we can worry about all the organization later, but yeah, Paul.
Yeah, thank you, Philippa. Given, let's say, the limitations of where we are in the humanitarian community right now, have you prioritized within those priorities? And is it going to be spaced out?
We discussed prioritizing and we never got to it, so thanks for reminding us of that. I mean, I think we have a couple of key priorities at the moment which are pretty much finishing some of the things that have already started. So that's around the mapping and the IATA protocol for response and emergencies. And that's what is the other one I wanted to say? And the clinical guidelines piece. But it's true that I think I don't know, Sylvia, if you have off the top of your head, but we didn't really go into the priorities beyond that. I think we have flagged, a couple of these, to be honest, are priorities that carry over from our previous strategy that we just haven't managed to activate. So that will be a lot of the things around the education of frontline healthcare workers, as well as the kind of peer support. So those would potentially be ones we could think about, given we've identified them for a while, perhaps time to move forward more concretely.
Right, thank you. Let's move on. If someone realizes they've got a question a bit later on, then they might be able to ask it, but in the interest of time, let's move on to the access work stream.
Okay, so we had a great discussion. I think our focus was a bit more narrow, which is actually really good, because I don't have to talk about a lot of things I don't know much about. It's interesting that this is my 5th symposium, and we're still, our number one priority, I think, is still pricing, and specifically pricing of pens, a consistent supply of insulin, whether it's pens or vial-based. And then now also we're increasingly thinking about this as a package, meaning not just the insulin itself, but also the glucometers, the test strips, they have to be lower cost. Because in some of the agencies, we're at a price point where the insulin, even in pens, even in analogs, it might actually be less than the glucometers and test strips, depending on how often they're being used, whether it's just facility-based or if it's home-based. And I think that that's actually a really nice synergy between our pillar and the service delivery pillar, which is in thinking about how do we push out more home-based insulin, self-monitoring, and along with that, better education and empowering people living with diabetes. So the first one is really about lower costs and prices. So it might seem that we keep talking about the same thing and no progress has been made, and that is not true. I think the conversation now is very different in 2025 than it was in 2019, where people were still kind of questioning about, should we be pushing for analog insulins because they're 10 times or whatever times more expensive than human insulins? I don't think that is the case today. So the conversation is definitely much more positive with respects to pens and with analog insulins. And so I'm quite happy about that. In terms of newer medications, we did not spend a lot of time talking about this particular issue, in particular because we did spend a lot of time also thinking about other maybe more innovative ways to get lower prices, which include things like pooled procurement or volume guarantees and different types of ways to try to do that for both the insulins and for the glucometers. In terms of newer medications, I think there's always a bit of a reluctance on one side. For type 2 diabetes, I think there are many of us who see the value of newer meds like GLP-1s and that we don't see them routinely available in humanitarian settings, not even being piloted really that much. And so it is an area that I have a personal interest in. That said, I think it is definitely secondary to the number one priority, which is lower cost, consistent insulins and self-monitoring. And then in terms of point-of-care technologies, we talked about this in the sense that it's related to self-management. And then from the facilities perspective, the humanitarian actors that were there did seem to report that there actually was pretty good availability of HbA1c testing, but that perhaps there could be opportunities for other types of testing like lipids or creatinine. So those are kind of the issues that we discussed.
Great, thank you, Jing. And just, well, let's give Jing a clap first of all. Sorry. And just before we open up for any questions, I think the pooling, I can't remember which point you said it. Yeah, for the pooling point, I think Bianca had to leave, but I think it's worth. I think there's an alignment there with ongoing discussions within WHO about pooling mechanisms. So I think there's a good synergy there. So maybe a follow-up. Any questions for clarification or great ideas? Yes.
Thanks. It was just around, it was interesting to hear you say that there's quite good access to HbA1c point of care. I know that in MSF we bring it ourselves, but was that across different organisations that there was a perception that it's quite widely available now?
I think so. I think UNRWA. Yeah. And then I'm also looking at Stefan back there. But yeah, I think HbA1c is available. Yeah.
So a lot of colleagues at LSHTM are working on NCDs in lower resource settings in sub-Saharan Africa. So, and it's not.
Yeah, but that's not
yeah.
I think that these are unique organisations for that. Yeah.
So
I think there could still be some work potentially to do on that.
on HbA1c, yeah, point of care.
On the point,
Could we have a microphone? Yeah.
On the point of HbA1cs, I've got friends in Gaza who literally have zero knowledge about their A1C levels for the past 2 years. And I'm not talking about one or two, I'm talking about tens of them. Especially those who are not children, so who not taking that. Sorry.
No, finish your point, please. No, if I can just add to this. And I think what stood out in our conversation was so much more the sort of wish list, the future look, right? Say, do some creatinine testing, be able to do some lipid testing, maybe thyroid function, you know. But I agree, I mean, we would never not look at HbA1c. I think that wouldn't make any sense. That would be negligent almost, right, in that entire package over. But the horizons might be different, right, in terms of the 5-year, you know, the wish list, good to have. It's a different starting point. We have a lot more data on, for example, technologies around HbA1c point of care, you know, compared to point of care creatinine testing, you know, or lipid testing. So we're different stages here. Yeah.
Great. Yes, Hamid.
Maybe just add, not to ignore blood pressure. I think it's as in the point of care. So I think it's important point. Yeah. Thank you.
Okay, thank you. Let's, Sylvia.
Did you discuss at all the how that might be different from what's been done already? We can hash it out later too. I was just curious.
Yeah, I mean, there were some ideas that were put out. For example, perhaps going through the cluster WhatsApp groups would be one way of thinking about it, because they already have these logistics WhatsApp groups where they talk about, hey, for this particular item, what are the suppliers? What are the prices that you get? Could something similar like that be done for insulin or for diagnostics related to insulin delivery? And then, of course, like, you know, working with colleagues, like, for example, at Chai or something, who have more experience in pool procurement. These are kind of some of the hows that were brought up.
So I think particularly with the pool procurement that you're referring to, things may have happened at WHO that I'm not so aware of, but I mean, that conversation's been going on for a very long time, right? And it kind of comes and goes and is hailed as the solution, pool procurement to better prices and stuff, but you know, and other times people get frustrated with it because it's so difficult. I think here we have an opportunity to, as IATA, right, to play a role in bringing all the information together and apply it to humanitarian settings and actors. I think that's the key thing, right? That, you know, how can that be leveraged, you know, that they have a common interest and a common need, you know? But it is not so, I wouldn't actually necessarily jump into the cluster conversation, but really first go and do a bit more of an analytical overview, you know, mapping, documenting, and not only pool procurement, right? But we talked about things like a volume guarantee, you know, or different deal structures, how to get to lower prices. But it first needs a bit of a market access exercise, if you like, right? And I think that is where IATA's role could be, right? To sort of define that TOR, what it is, find a suitable organization to do that with, you know, and then inform from that going forward, you know. I mean, we're talking about 5 years, so, you know, starting with a thorough, you know, and that would include speaking to things like the clusters, obviously, very critically, and other key actors. But I think that could be something we can discuss, you know, to think it through carefully, and then, you know, have a good roadmap based on data and informed stakeholder consultations.
Good. Yeah, perfect. Right, thanks. Let's move on. So on to the third working group, data and research. Avin.
Okay, so while we're waiting for the slide, we can say thanks to the group for a really lively and interesting discussion. And to make the point, I suppose, that research is cross-cutting. So there is some specific activities we can do as a work stream, but a lot of what we want to do is to keep track of what everybody else is interested in doing in terms of your individual work streams as well. Shall I move forward? Yeah. Okay, so we had just 3 defined priorities, and then the red text is what we've added now based on the discussion we've had, and then afterwards I can just briefly mention a few of the activities. So what we had said was strengthen the research ecosystem, which involves developing the research network, developing and influencing the research agenda, and supporting research capacity and quality. So what we've added based on the discussion was making sure to specifically, explicitly include people with lived experience within the research ecosystem, to engage with funders, to influence their strategy and potentially to be a broker as IATA with funders. So we influence their agenda, we influence the wider group's agenda, and we act as a broker potentially between the members of IATA and funders. And then to engage other WHO NGO bodies is just shorthand to fit on the slide, but essentially we named multiple other organizations like IOM, WFP, UNICEF, who were on Philippa's slide as well, and specifically to engage with them in terms of their research priorities. But there are also bodies within WHO engaged in modelling and who have access and who are collecting great swathes of data. So trying to tap into those existing resources and bodies of knowledge is part of what we propose to do. And part of, more detail on what research capacity and quality building would involve, we've suggested, is to engage in training, and that may be through making open access global research goods available. So it might be through making, tools available to people, making code or, analyses, regression analyses available, having a community of practice where people will discuss the methods they used and the lessons learned, and we can share those kind of experiences with the wider group. And of course, disseminating research outcomes in order to use research to be more influential. So understanding what research is happening, understanding what the outcomes of that research were, and then bringing those outputs to the wider community as well to try to influence things moving forward. The second key priority was about building predictive tools for smarter response. So we've previously, and it came up, I know, in our research exercise earlier, but the idea of developing a transparent modelling tool to estimate the impact of care disruption, predict acute needs, and guide response is something that's been discussed for a long time. We probably put it into writing first in Krakow, and just the interest is building. Part of the discussion we had then in the group was about not just the people like in organizations within WHO, academics and so on who are already engaged in modeling, but people, organizations like Google, Facebook and so on who are doing some work already in terms of tracking displaced people and who, are very excellent at this, and that we should potentially engage with them to learn from their expertise and maybe to engage them, and maybe they have philanthropic arms interested in engaging with us in this work. And linked to that, the idea of the use of big data, alternative data, sources, all the data we constantly share about ourselves on smartphones. There must be great potential there to use that to help in the response, and put the potential for AI as part of that in terms of how do you analyze big swathes of data rapidly. So finally then, integrating diabetes into, initially it just said monitoring tools. So the idea is to ensure that diabetes and broader NCDs are embedded in key humanitarian sector-wide assessment and monitoring tools, but also slightly linked to point one was the idea that in evaluating interventions, we should be ensuring NCDs are included as well. The how-to of the evaluations maybe is covered by point one, but just ensuring that NCDs are, we're gathering data on them throughout the process, and analysing that and disseminating it would be part of 3 as well. Practical things in terms of how-to, I suppose we talked about the long-planned regular meetings that we want to just expand the network, including expanding the formal partners of IATA, as Kieran mentioned, but also engaging with many of the organizations I mentioned, and then having regular meetings where we discuss what everybody is doing in terms of active research, disseminate findings, and again, strategize on the next steps. And potentially developing things like a short course and a research-focused meetings and so on to get this community together. I think that's everything. So did anybody else from our group want to make any additional points? No. Or any comments from the floor? Paul?
While we're giving the mic to Paul, let's give Avina a round of applause and the group. Thank you.
Thank you. No, it looks great. In our group this morning, we talked about indicators and the need for standardized indicators, how to measure them in different contexts, et cetera. It probably would go into zero, could go into 0.3, into 3.
Yeah, in fact, that was there in the zero draft, but somehow it was removed in further drafts. But no, that should be there, definitely, Paul. Thanks for pointing that out. Yeah. Kieran?
Yeah, I think that's right. I think I think we removed developing indicators because they're already a set of draft indicators that have been developed. So the task ahead is now to align and agree and actually bring together two streams of work that have happened in parallel, a stream of work on this within WHO and a stream of work on this within the informal interagency working group. So the material is there, and now there's a sort of work on aligning and agreeing. And that will be a priority, I think.
Yeah, so Angelica and I had brought forward the work of the Interagency Working Group, and we're about to report on what we've done and share it with others, including WHO. So yes, no, definitely that will be part of the tasks going forward. Thanks, Paul. Philippa?
Yeah, no, I was going to ask about that one as well, because I think it would be a priority. We have to finally finish that work. But then the second one was just if there's anything around the work that was done this morning in terms of identifying, disseminating, sharing the research priorities.
Definitely. I suppose, again, it's shorthand, but that would be part of the
first one.
The first
Yeah.
one, for sure. Thank you.
So just on that point, so I think on the program, there was going to be a little voting session at the end on research priorities. Evine, do you want to just say a word on that about what we're going to do about that?
Thanks, Kieran. Yeah, so we've decided, mainly just because it's been a long set of days and it takes brain power to vote. So I think we're going to actually ask you to go away and think about everything you've heard and everything you've contributed today, and then we will email everybody who's come to the symposium, because always at the end of the 2 days we've lower numbers as well than we had at the beginning. So we'll email you all, send you a QR code, and ask you to do a 10-minute voting exercise on a revised set of questions. So I will revise them based on all the discussion, and then literally we just want you to tick, select 5, and we'll bring that forward then as we continue this discussion. So thank you.
And you're allowed to take more than 10 minutes on it if you want to. But it will take me more than that to understand some of the questions. But I think, but great, thanks, Evine. So, Jay, onto the fourth pillar. So this pillar has gone by many names. It's evolved over time. I think we first called it advocacy, then we called it advocacy, then we called it policy and financing. I think today we call it advocacy for policy and financing. But it's about policy and it's about financing, and it's the things that need to change.
So thanks so much to our group. We had a really rich discussion. I'm trying to work out, we talked about things a little bit differently, given our name. We are contrary, but we've adapted the priorities and added a fourth one. So maybe we'll go through the priorities and then I can kind of pepper it with some of the discussion. But one of the points that did come up is where advocacy sits and kind of the need for collective action around communication and advocacy, but we'll maybe come to that after. So the first priority is strengthen integration of diabetes and NCDs in emergency preparedness planning by working with and strengthening the capacity of IADA members as needed to provide support to countries in strengthening their systems, and by working across sectors including nutrition, food systems, maternal and child health. And that, it's a bit of a mouthful. I guess it's that point of, as Rachel said, kind of not losing food from this particular one, but also thinking about how do we integrate across as many kind of different platforms as possible and really making NCDs and diabetes everyone's business, and thinking about the skills and capacities of our membership, but then also looking beyond that membership at who else we should be bringing into the fold. And that's not just kind of thinking as well across the acute settings, but also the protracted. So for instance, the food side, WFP, but what about FAO? What about others in that space? And also thinking across the humanitarian development peace nexus. So the second one is improve the coordination and transparency of financing across partners working across the humanitarian development peace nexus to ensure prioritization of diabetes and NCDs. And I think before the language was ensure financing, and that felt like a very big ask for our little group. So I think we were kind of thinking, well, what is it that we can do? What's come up through the 2 days? And there was this point around kind of the coordination of how we work, knowing what funds are flowing where, and kind of trying to encourage transparency about it, to really make the case for, are we prioritizing diabetes or are we not? And if not, how do we kind of understand what the cost of that is? And so that leads to different actions around mapping of funding flows, also how we work across with partners, thinking about what platforms we might create to help further that conversation. The third one's integration into the emergency response side, so strengthening through collaborating with humanitarian implementing organizations and normative agencies. And this is looking at the kind of work we were planning at all levels, so thinking international, also regional, and national and local level, as we've talked a lot about localization, and what kind of templates or models or approaches might there be to understand what is needed, and then how we might, as IADA, support those, whether it's through a mapping exercise to understand different players on the ground, whether it's kind of trainings or workshops that can then be disseminated by partners through the regions. I think one of the phrases I liked the most that came up was from yourself around kind of seeing IADA as a catalyst and making sure that we're kind of synergizing or kind of amplifying the impact of our membership. That was me, I need to. And then the fourth one we've added in, so we've come through the kind of UN, well, we're coming through the political declaration, the UN high-level meeting, and so if we look what's next, and Alison raised the points around the redesign of the global health architecture. We don't know what will come around that, but how do we make sure NCDs are in there, and how do we make sure humanitarian settings are in there? So seeing whether we can be part of that conversation, either as IADA or through our membership. And then also thinking about the SDGs, come 2028, those will start to be renegotiated and reconsidered. I mean, how do we get NCDs in there for, centrally, and how do we make sure humanitarian settings, again, are in there? So that was kind of where we got to. Sorry, I've lost my page. I think those were the main things. I think a lot of it was around, we're all friends in this room. How do we find those that aren't yet friends and bringing them in the fold and making NCDs, making diabetes everyone's business?
Great. Jay, can I just ask you to go back one slide, just on the financing bit? So it feels there's something new here. I know you said it, but can you say it again? Because something new has emerged from that discussion that wasn't there before. What's the difference?
So I think previously, let me go have it open here. So previously, our language was ensure financial commitment, advocate for ongoing prioritization of diabetes and NCDs by implementers and funders, develop targeted financing initiatives, so investment cases through collaboration with funders. And I think there was a sense of it's very hard to ensure financial commitment. There's also this point around the humanitarian development peace nexus that we need to really think about what we're asking for within that space. Obviously, we need more finance, but how and where from and who? I think that links a little bit to Rachel's point on the private sector as being one of the main deliverers of care. How do we engage? It's a tricky one to deliver, so we then looked at it differently, and we were thinking based on panel one, I mean, we don't even know the financing situation, so how do we even start from there? And then how do we get us all to coordinate around it? So that was kind of, we tried to make it more doable rather than unachievable.
Great. Look, thanks, Jay. I just want to then open up if there are any questions or comments on that last work stream, or anything missing.
disagree on the kind of, the tenets of that.
So I think you've done a great job, because sometimes in these discussions, once the discussion is opened up, it just goes wider and wider and wider. And in most of these cases, we've actually become more specific as a result of those conversations. I think there's some very actionable points there. This gives a good first draft moving forward. And I would say this, the output of this session is a first draft of a strategic plan. And sometimes drafts of strategic plans go into many drafts. I've worked with MSF. We went to 26 drafts for a particular guideline, the cholera guidelines. But our intention would be after this to pull all this together and share with the IADA community, because not everyone is here. Many people are online, but there will be a chance to review and revise and feed into this, and also for organizations to actually start to look at the detail and see where, as I said, where do I see my organization in this? Because I keep saying this, what we have to remember is what we're trying to achieve here is not a list of objectives for Jay, Aveen, Jing, and Philippa to work on, but a list of priorities that we share across the Alliance. And yes, the role of IADA Secretariat is to facilitate where possible, to do, to support, to drive, to enable. But the success of IADA is based on, or any sort of collective impact initiative is based on a shared ownership of the problem and in a shared engagement with the priority actions that come out of it. I want to just, at first I planned to try to identify the 3 to 5 activities that we thought would be mission critical. I can't do that, but I would like to highlight a few points that have come up, particularly from today or over the last 2 days, that I think are new for us, or were not quite articulated in that way in our in our earlier plans. So I think one of the things that's come up again and again is preparedness and readiness. That at first I think our focus was very much on response, and we see more and more that there is scope as an alliance to work on preparedness and readiness, which actually felt really difficult at first, because also this is where state engagement with states is often very necessary. But as has been discussed today, we have multiple entry points across the alliance, and I think that that's a real possibility for us. Access to affordable insulin, but also the bundle of diagnostics remains a clear priority. I think, as this discussion showed, access to HbA1c is still extremely relevant. One thing that's come up a few times is capacity development, health worker capacity development, including on research capacity, because I think health workers across all humanitarian contexts are in the unique position to be able to inform and to share and to inform the global community and to drive change. But they need time, they need resources, they need access to training. And I think, especially on research capacity, there are some initiatives considered underway to try to make capacity development available to health workers in humanitarian settings. And then the same goes for people to self-care, self-management skills. This is something as well that I think has come up a few times. And all of these should be accessible as global goods. So there needs to be real access to these resources for free, of course. Developing and influencing the research agenda, has come up several times, but also in a connection with funders. Also speaking more with funders about what their priorities are, and also sharing the priorities that we've identified in terms of research and other priorities to inform the ongoing development of funders' priorities. Alignment on NCD indicators for monitoring in humanitarian emergencies. I mentioned that just because it has come up again. This is something that has been worked on for several years. It's still relevant, it's still a priority. Nutrition and pregnancy are specific topics which will require working across sectors. Again, that's come up, of course, we had we had 2 sessions on that. It's not surprising it comes up, but I felt it's been mentioned again and again as priority, as I said, working across sectors, food systems, maternal child health. The point about NCDs in the global health architecture and the next iteration of the SDGs, the Sustainable Development Goals, this wasn't something that was on the agenda some years ago, so I think that's a new reflection. And the point about transparency of financing and clarity about what we're asking for, because we have had policy financing advocacy on the agenda from the start, but it is true that we have not necessarily clarified what the ask is. And then finally, on these sort of global priorities, there's one point that's come up again and again. Again, of course, we did have a workshop on this yesterday, so I'm not entirely surprised. But the discussion on meaningful engagement, for me, I feel it's moved forward. And what I feel personally I've heard is not just that it's a good thing to do, but actually that we need to look at the range of modalities, but also all our activities. Meaningful engagement is not actually just about something that's relevant at the point of getting feedback on services so you can adjust those services. It's not just about co-production, and it's not just about sharing the outputs of research when people with lived experience weren't involved in defining the research. It cuts across all our activities, including the things that we all know but we've all forgotten. Developing sensitization materials, developing patient support tools, how much listening goes on when we develop those tools. And I was struck by several examples I was given of tools that were developed, and only 2-3 years later we realized we'd never actually listened to people when we developed these tools, and we were using these tools and they were not addressing people's needs. So I think that is a theme that keeps coming up. I'm nearly done, but one of the other objectives of this session was just to start to think about the enablers. As well as what we are trying to do, what is the goal, what do we need to do differently? How do we need to work differently? And I think what I've learned from the discussions is that it's not that we need to do things differently, but we really need to do them. So we really need to do what we've been trying to do. The point of a collective impact initiative is we need to be communicating really regularly. We need to find ways that meet the needs of all of the members of the Alliance, to share information, to connect, whether that might be quarterly calls for certain topics, it might be a completely different modality for other topics, but community management or working together as an alliance is going to need that, thinking through for each of these priorities, how do we engage with each other, how do we keep that momentum? And it also involves identifying and making available shared resources across the Alliance, because we do have a lot, but we need to think about how to make sure people have access to what they need and what is already available. And very much linked to that is the sort of model of engagement. I was saying in our breakout group that we started off, I think after Boston or after Krakow, with 160 organizations that expressed strong interest to engage with IADA. And then over time, some drifted off. There was reprioritization, there were funding issues, and the number of organizations has waxed and waned over time. But one thing we didn't do at that time, and we've started to do gradually, is really think, what does that engagement mean? How do we consolidate that engagement? And we feel that means having a conversation with each and every organization, one by one, understanding what the priorities for that organization are, what are the gaps, what do they want to work on, how can we work together on this? And then starting to match up and realize who's working on what. And that level of granular detail is needed to really get the benefit of an alliance for everyone working together. And then we need to monitor the progress, because once we've agreed we're going to all work on this particular topic, we need to hold ourselves to account, a sort of mutual accountability, because we're not the boss. We are what we define the Secretariat as is a sort of backbone organization that tries to help everything work together. So we've started that process, and I think that we've had those in-depth discussions with the first 10 organizations, and we would like to continue that so that one by one we speak to every organization. And then the final enabler that struck me again, time and time again, is that point where I've sort of said it in the what, but it's also in the how, reaching out to funders to be aware of their investments, to inform their investments. And also, they have tremendous technical expertise sometimes, probably maybe always, so I don't know because I haven't reached out to them. So I think we need to look at that. We need to look at that sort of more that type of engagement that respects the expertise of the partner. And that, I think, has been a lesson for us of the richness of that. So that's a quick summary of some of the key points for me that emerged from this discussion. As I said, we're going to pull all this together and share with everybody a first draft of the strategic plan, and there will be that chance to comment, and then after the comments come the commitments. So, but these are voluntary commitments, but we need to have those discussions as well, because an alliance, that's part of being in an alliance.